This is our first seminar of 2026 for our Human Factors Working Group. This working group is funded by the National Institute for Health and Care Research as part of the supporting researchers in the 6 patient safety research collaborations that's collectively known as SafetyNet. And we have established a working group to support people who are working as patient safety researchers. And we've also really welcomed expanding our group to encourage practitioners across healthcare and different people interested in human factors to come and share their learning and collectively work together to see how we can expand how we use human factors in our patient safety practice and research. Today, we're going to be hearing from Fran Ives. Fran is a Fellow of the Chartered Institute for Human Factors and Ergonomics, and indeed is President-elect. She'll be taking up her position as President of the Chartered Institute in April this year. She's worked in a range of different industries, including healthcare for a number of years, but also brings experience from the automotive industry and nuclear industry, and is currently working as a Mobilising Fellow at Keele University. She's going to talk to us about her experience of using human factors for different projects in different industries and how she's mobilised that knowledge to move from gaining insight into how people work to actually putting it into practice to improve how people work and the outcomes that they're getting. We're really looking forward to hearing how Fran works, and she's going to talk us through some discussions to help us think about where we're using human factors in our own work and how we can start to mobilise that knowledge for impact. So thank you very much, Fran, and over to you.
I'm hoping that people will join in with the discussion today, because it's always really great to get ideas and thoughts from people on the call. So I will be asking some questions, just questions that you can put in the chat if you want, or you can come off mute. Either is fine. So thank you for inviting me today. As Brooke said, I'm a Chartered Human Factors Specialist. I've been in healthcare for a long time. And in fact, I've worked in healthcare for over 20 years. But my route into healthcare human factors was probably a little bit different from many of the people who are working in this field, because at the age of 18, I took the fairly unusual route and made the unusual decision that I wanted to be a human factor specialist. So went off to Loughborough to do an ergonomics degree, which sadly now no longer exists. So I spent 4 years at Loughborough, a year of that doing a year in industry in the automotive sector. And then upon graduation, I moved into the nuclear industry. These were 2 industries I didn't really know anything about. But I think being at Loughborough and doing a really great general degree, it gave me that really good foundation to actually be able to go into those industries and be able to learn my craft, really. And these were 2 sectors, particularly the nuclear sector, where human factors was really embedded in the design, the safety and the performance. And I think those years in the automotive and nuclear industry really shaped how I approach human factors and challenges in healthcare. I was actually quite nervous about coming into healthcare because I had no clinical background. I didn't really know anything about healthcare, and I thought that would work against me. But I actually very quickly realised that it could be used as an advantage as well. Because I wasn't a nurse, I wasn't a physio, I had no preconceived ideas, no mental models about how work should be done. I could go into all of these different spaces and ask the seemingly obvious questions. Tell me more about this. Well, that's interesting. Love to learn a little bit more about why you do things that way or how you do things. And using that inquiring mind, combined with those fresh eyes, turned out to be a real advantage, because often people do things the way they've always done them. And actually inviting people to explore and to tell you about what they're doing gave them an opportunity to sort of take a step back and think about the work they were doing and how they were doing it. So today, what I want to do in this session, which is called Mobilising Human Factors Knowledge for Impact, is to really help you recognise the human factors principles that you're already using in your work, even if you're not calling yourself a human factors specialist. And once you've recognised those, really get you to think about, and I'll give you some ideas as well, as to how you can amplify their impact. One of the reasons why I'm really interested in knowledge mobilisation at the moment is, you'll see from my title, that I'm currently a knowledge mobilisation fellow at Keele University. So I'm fairly near the beginning of this fellowship, and this is all about taking knowledge from research, information that can really be of benefit and use to healthcare, but actually taking it and putting it where it actually is going to do some good. You know, it's all very well people doing research, but if it isn't actually shared with the right people in the right environments, then we're missing an opportunity to actually make improvements to healthcare. And so I'm really interested in looking at how we can mobilise human factors. You know, how can we share the brilliant work that is being done so that more people know what human factors is, more people use it, and we can hopefully create a bigger impact from the brilliant work that's being done. So I'm going to start off with a story. And this project began with a simple conversation about a nurse who had a problem. And this particular nurse worked at Birmingham Children's Hospital, and she wanted to learn about point of care ultrasound. Some of you may have heard of this. It's often referred to as POCUS. And she wanted to use POCUS to help make better decisions when she was treating bleeds in children with haemophilia. And when she'd started to explore this, she asked around, particularly about training. You know, it's all very well buying the piece of equipment, but you need to know how to use it. So she was trying to explore where she could go to be trained on this particular piece of equipment. And the answer she got was, nurses aren't allowed to do POCUS. She felt a bit stumped, like she'd hit a brick wall. And that didn't really sound right to us at West Midlands, Health Innovation West Midlands, where I was based at the time. And that seemed like a really sort of, you know, backwards step, really. And it seemed a real shame that this person was coming up against these brick walls when she was trying to be quite innovative and trying to make improvements with her service. So we checked with the Royal College of Radiology and discovered that nurses are allowed to do POCUS. So that was the first myth busted in this particular project. So from there, we met with the nurse and we really tried to understand her challenges and really tried to explore how this handheld ultrasound technology could support her in practice. And so this was really the start of a journey to try and break down barriers and rethink what is possible for clinical roles. So point of care ultrasound, or POCUS, is a bedside procedure, and it's often used in acute medicine to support assessments of patients and decision making. The technology, the ultrasound technology, is not new, but how we are using it today has changed dramatically since how it was used when I first joined healthcare over 20 years ago. And at that point, traditionally, ultrasound scans meant large, bulky, heavy machines in dedicated rooms. And I remember years and years ago doing a project with echocardiographers, so staff who were doing ultrasound scans of the heart. And they really wanted to go out and do more bedside scans, but the equipment they had, those really bulky, old, traditional ultrasound machines with CRT monitors, were just so heavy to move along corridors. They had to really fight to get more of a laptop-based machine, which at the time seemed really high-tech. But things, you know, thankfully have moved on. So we're no longer having to take patients to dedicated rooms. Today, we've got handheld probes that can be connected to a tablet or a smartphone. And that means that it's possible to bring that imaging very easily right to the patient's bedside or the patient's home. You know, it doesn't have to even be done in a hospital setting. So this has produced quite a transformational shift, enabling faster decision making, which can improve patient flow. But the real challenge is that whilst the technology has evolved, the NHS hasn't always kept pace. So processes, training, and role boundaries are often lagging behind, which can then create barriers to adoption, even when you've got really, really motivated staff who really feel that it's going to make a big difference to them, but also their patients. So the haemophilia unit at Birmingham Children's Hospital provides specialist care for children with bleeding disorders from birth all the way up to 16 years old. And they are a really brilliant centre in the region. And they work closely with a lot of the other haemophilia centres, particularly the adult ones across the region. So the patients that they were particularly interested in making improvements for were children who came in with a suspected joint bleed. So this could be if a child had fallen over or they'd done some exercise, it had a bang or a knock. Suspected joint bleeds could happen spontaneously, perhaps, after an injury or a knock, and they would usually affect the knees, the elbows, ankles, or hips. And repeated bleeding into a joint can lead to long-term joint damage. So it's really critical that timely treatment is given to these children. So when a child came in with a suspected bleed, the team really needed to try and confirm quickly what was happening. Is this a bleed or isn't it? And ideally, that confirmation would be done using ultrasound. But in practice, that could often be quite difficult because the nurses would have to phone up radiology, beg, borrow, and negotiate a slot with them to try and get that child seen as quickly as possible. And if there wasn't a slot available, the nurse would either give them clotting medication as a precaution, which isn't ideal and it's also very expensive, or they would have to sort of just ask the child to sort of, can you just stay a bit longer? We'll try again in a little bit. And if the child was given factor medication and told to come back the next day, that's extra trips for patients and parents, extra time off work, extra journeys, extra expense. So it's not an ideal situation. So this is where the idea of the point of care ultrasound came in. The nurses wanted to be able to reach in their drawer, grab their POCUS and be able to scan that joint there and then, not to make an absolute diagnosis, but just to inform their decision making of what they did next and to be able to know very quickly, is this a joint bleed or isn't it? So we worked with them to not only identify training, but to also identify possible equipment types that they could use, what would work for them, what wouldn't work. We brought one into trial. And we also got them to think about, we worked alongside them to think about how implementing this new piece of equipment was going to change their work processes and the way they work. Because what we didn't want to happen was for them to implement this new piece of equipment without thinking about the wider system effects, and to then just expect that everything was going to work and everything was going to flow really nicely. So the piece of equipment that they used was produced by Butterfly, and we've got a Butterfly probe here. And Butterfly are a really open company to letting people trial things. And as a human factor specialist, that's always a way that I want to work. So many really expensive bits of equipment have been bought without trial, and then they've arrived and they haven't been the right piece of equipment. And then staff have that really awkward decision of what do we do with it? Do we just quietly put it in a drawer and forget about it and hope nobody remembers we spent a lot of money on it? Or do we just kind of plough on and hope that we can, implement workarounds and kind of get what we want? So was POCUS the solution here? Well, actually, no, not quite. And certainly not at the moment. So whilst the technology was really promising, through doing this piece of work, we found that there were some real practical barriers to making it work in this particular setting. And whilst we tried to tackle the training really early on, this was still a bit of an issue. So this isn't just about the equipment. The training and mentoring when you're learning POCUS is absolutely essential, and having enough staff being able to mentor is really important. Finding a mentor was quite difficult. Staff were also finding that they didn't have enough of these children coming in with joint bleeds for them to practice enough, to build up confidence, to build up competence as well. They also found that with this particular probe, because it's one size, that's great when you're scanning older children or adults. But if you've got a baby coming in or quite a small young child, then that handheld probe was just too big for some of the small pediatric joints that they saw. So while some people might say, well, that wasn't a successful piece of work, actually, I think this was a really successful piece of work because all of the factors show that while POCUS in this particular situation had huge potential, the successful adoption really depends on more than just that one device. You know, it requires the right support, the right mentoring, it requires the right processes, as well as the design of the equipment, which in this situation wasn't quite what we wanted. So I want you to have a bit of a think now, and please do write in the chat if there are any projects that you have done that you've not labelled necessarily as a human factors project, any projects where you've thought about the usability of pieces of equipment, where you've thought about the safety of patients, of staff, or maybe you've thought about workflow. So thinking about examples such as, planning workflows for clinicians, creating user-friendly apps, or thinking about the interface design, these sorts of things that you've actually included in a project. So just take a moment to reflect, and please just type in the chat if you've got any examples of where you think you might have considered and used human factors. And I'll see if I can bring you all back up again. Brooke, I'm struggling to see people. Can you let me know if there's any examples in the chat?
I can. So we've already got one, which is a project over COVID looking at surgical efficiency.
Oh, lovely.
Do you want people, if they're happy to unmute themselves and give some more detail, do you want people to put their hands up?
Absolutely, yes. Could you control that? Because I can't really see people very well. Are you able to do that for me?
I can keep an eye out for that. We've also
Thank you.
an ongoing project working on EPCR, having to build it from the ground up. And it's a challenge to get all the clinicians to use it in a way that means staff and admin can see the right info at the right time.
Oh, that's a great human factors challenge.
Yeah.
Excellent. Please feel free to keep adding them. It'd be great to have a look at them at the end. So if things come to you, is there anyone that wants to expand? Or are we just going with the chat at the moment? Going with the chat. Keep thinking, keep writing in the chat, and I will continue and other thoughts.
Fran, I'm happy to talk about it, but I'm just eating a chocolate, so bear with me.
Should we come back to you then? I don't want to disturb the chocolate consuming.
Would you like
I'm
it?
good. I'm good.
Yeah.
If you want me to talk about the
Yeah, go for it.
So the service I work in at the minute is a tri-service agreement between 3 different NHS trusts. Therefore, it was decided that we should have our own Epic build.
Yeah.
And because of that, that meant that we couldn't use Great Ormond Streets, which is where I work, regular one. We had to build it from the ground up. So we've had to build this entire Epic system to talk to Gosh's system and to work with a service where hardly anyone works full time. And other people work in different services where they don't use Epic. And we've got a lot of issues at the minute with sharing information externally. So we need to be able to share that securely, and we can't do that because we're not allowed NHS Net emails. It all gets very, very complicated. And things like booking in sessions for clinicians, because they're only in the service for a few days a week, they don't like using Epic because it means they have to log on and do all this stuff.
Okay.
So we're finding that people are going, oh, I didn't realise I had an appointment, because they didn't check Epic. They were checking their normal diaries, for example. And people are
Okay.
struggling with smart phrases, so putting in the right information to get letters set up or referrals
Mm,
sent out to the right people at the right time. We're really struggling with it. And I think the
mm,
answer is more experience and getting the
mm.
build right, because it's still not
Yeah,
perfect.
yeah,
But a lot of that's down to governance and the agreements that we've got, but we're really struggling with it at the moment.
yeah. That sounds like a huge challenge, but it's also a great example. Thank you. Thank you for sharing that, Jordan. That's maybe one that we can come back to at the end, because otherwise I could chat about that for the rest of the session. Um, Excellent. Right, I'll move on to the next slide and really sort of pose the question of whether human factors should be applied proactively or reactively. And I think too often human factors is brought in after something goes wrong. And I think possibly PSERF is probably not helping here, because we're one of the great things about PSERF is that people are talking more from a systems perspective. They're talking about things like the SEEPS methodology, which is for a human factors specialist who's been in healthcare a long time, to hear this, to hear people talking about systems, about human factors, about SEEPS is absolutely brilliant. Now, SEEPS as a framework was never designed to just be used when something goes wrong. It's designed to be used at any point in a process. It can be used before you actually start on a project, partway through, as well as at the end. And I think that's one of the messages that I'm often trying to get across for people, that actually human factors can be brought in right at the very beginning. So yes, we can use it really successfully when we're looking at investigations and things like that. But there's a real opportunity to be proactive and to embed human factors thinking really early. And as a result, ideally prevent issues from occurring. By identifying issues right at the very beginning, hopefully we don't have to do so many investigations at the end. Now, I wouldn't say any industry gets this right at all. I do have experience in automotive and nuclear. I would say nuclear, from my experience a long time ago, we were probably a bit better at using human factors proactively. It's a heavily regulated industry, and so there was often a requirement that human factors was included in a project. The engineers might not have liked that, but often they didn't have a great deal of choice. But what I'd really love to see in healthcare is for us to move into that direction and to really start to use human factors proactively. But it's a bit of a challenge, I think. How do we get ahead of interventions, and how do we make human factors part of the design process rather than a fix at the end when something's gone wrong? But I want to bring in an example from the nuclear industry. I think as a human factors specialist, I'm always interested to learn from other industries. I think healthcare has a lot to learn from other industries. I think other industries have got a lot to learn from us as well. Historically, we have looked at aviation, but I think, we need to look a lot more broader than that. And I will always encourage human factors specialists to really be open to working in different industries, because whilst nuclear is very different to healthcare, there was an awful lot of knowledge and experience that I could bring from nuclear into healthcare. And it's really interesting to think about this particular piece of work that I'm going to be talking about, because it's all to do with fatigue, and a trial that we undertook to look at extending shifts from 8 hours to 12 hours. And this was sort of, 20 years ago that we did this piece of work. But it's only in the last couple of years that we've really started to talk about fatigue in healthcare. And some of the things that we're talking about now, we talked about in nuclear quite a long time ago. So there was an idea mooted in one of the stations to move from an 8-hour shift system to a 12-hour. And it's not as simple as just rolling out a new shift system. We had to really think about the safety of the staff, the safety of the power plant, and also understand not just the impact of moving to 12-hour shifts on the safety, the performance, but also on the well-being of the staff as well. So before any decision and any vote was made over whether they change from 8 hours to 12 hours, we undertook a trial. And we looked at several dimensions during this trial in terms of data, comparing it to baseline data prior to the trial beginning. So things like looking at the alarm response time, so how long it took people in the control room, which you can see pictured, how long it took them to respond to alarms, because this was a real key indicator of vigilance and cognitive workload. So we wanted to know whether there was a significant difference between the length of time that alarms were being responded to before or after the trial. We also tracked error rates, we tracked incident reports, indicators that fatigue, particularly towards the ends of the longer shifts, were increasing or not. And one of the most interesting parts of the trial, I think, was doing the qualitative interviews, where we spoke to people from all across the power plant about their experiences on the trial, moving from 8 hours to 12 hours. And I hadn't quite expected, such emotive interviews, the honesty from people, and then bringing up things that, I hadn't necessarily really considered in terms of impact on their lives. So some of the pros, moving to 12 hours where there were fewer handovers, so that really could reduce the risk of communication errors. They had longer rest periods between shifts. So if they were contracted to work a certain number of hours a week, then they would need to make less journeys into work in order to complete their contracted hours. And they would always also then get longer rest periods off, which people absolutely loved. Some people, this was a power plant up in Lancashire, and some people lived quite far away. So actually, on one hand, they really liked the 12-hour shifts because they didn't have to commute as many times. But then equally, on the disadvantages, the cons, increased fatigue and reduced alertness in later hours. We did have some quite alarming stories of people like really struggling to stay awake on their drives home if they were commuting quite a long distance. So all of that information helped us to really understand what an impact this move was going to have if it was implemented. So, we looked at not just the technical performance, but also those broader system perspectives. We looked at the people, we looked at the processes, we looked at the organisation outcomes, and really tried to use that to help the organisation make an informed decision. And they did actually vote to go for the 12-hour shifts. So part of what I want to do today is to not only recognise human factors work that you already do, but really think about how we make that impact visible. Now, I know you've had a lot of sessions about what human factors is and, sort of how it can be applied in healthcare. And I think, from speaking to Adam and Brooke, the reality is a lot of you are doing some really great human factors work, even if you are not labelling it as that. But that work is being done, and that's brilliant. The challenge really, I think, is showing what impact and what difference human factors has had, and really demonstrating the results in a way that's easily understandable and can hopefully then be carried forward to have greater impact, but also that a greater number of people really understand what it is and why it's worth using. So I'm going to tell you about a project where human factors knowledge was mobilised really well, I think. And during it, I want you to really try and reflect on your own experiences and, think not only about pieces of work where you've undertaken human factors and applied human factors principles, but are there any examples of where you've shown people what you've done and how you've done it? And I don't intend to add any extra work to you, to your projects, but, is there a way that we can really just make sure that the value of what we're doing is made really clear to our audiences. So I want to share a project that was done by a colleague. So I can't claim this as my work, but I have been involved in this sort of from the sidelines for a number of years. And actually, quite by chance, I had a conversation with one of the lead nurses from, again, it's the Children's Hospital yesterday, and this piece of work cropped up again. So I think even though it was done a few years ago, you know, the legacy of this work is still absolutely, you know, there, and it's still viewed as a really successful piece of work. And human factors was a central part of that. So I think this is a really good example of what we mean by mobilising human factors knowledge for impact. So I feel like I'm picking on Children's Hospital today, but hopefully in a really positive way. There was a team there a number of years ago who worked on improving the paediatric early warning system, or PEWS, as you may have heard. And they wanted to make it better. They wanted to improve the layout of the form and that sort of, you know, physical element, the aesthetics, but also the usability. But they also wanted to better incorporate parental concern as an integral part of escalation. So the challenge was really clear. Parents often, not always, but often notice subtle changes in a child's condition before the clinicians do. But the previous PEWS process didn't really give them a structured way to share their insights. So this was why really the team brought in human factors expertise to try and redesign the PEWS chart, but also those associated processes. So they involved and engaged with over 100 nurses, 50 parents. They ran focus groups. They applied human factors principles to the chart design to make it more logical, more user-friendly. And one of those key changes was, as I said, moving that parental input to the top section of the form. They also spent a lot of time thinking about the wording of the question to parents to give them permission, if you like, to share their observations. And they really thought long and hard about how to ask that question, because if you say to someone, you know, how's your child looking? You know, have you got any concerns? It's very easy for a parent to just respond back and say, no, everything's fine. So what the team decided to do was to ask, how is your child different from the last time we asked you? So they didn't ask, is your child different? They asked, how is your child different? And even if the parent responds by saying they aren't different, staff still feel today that that is a more considered response, because they haven't just said, yeah, it's fine, no problem. They've actually had to think about it. So it gave parents sort of that encouragement, hopefully, to give them an opinion. And by putting it right at the very beginning, it meant that a parent wouldn't be put off by raising any concerns if they knew that all the observations had been absolutely fine and then they were asked any concerns. They might think, well, actually, all the observations are fine, so I don't really feel like I can raise anything, but I've got this niggling feeling that something's not right. So by moving it to the top, it gave them opportunity to say what they wanted before any observations had been taken. So the results the team felt were really quite powerful. Parental engagement increased quite significantly, and nurses reported earlier signs of deterioration. So it was felt from both staff and parents that this redesign of the process was really important. Now, the really, I think, important bit for today's discussion isn't the success it had in the Children's Hospital. That's great, But because the team actively shared their work, they talked about it within the hospital, focus groups, dissemination, audits, but they also talked about it more broadly outside of the hospital. And as a result, the project gained national recognition, and it became the foundation for a national Pews initiative. And so what the children's did, that form they produced, was the basis of what was rolled out nationally. And the national team, when they were looking at what needed to be done to take that form from a local trust nationally, had a really strong human factors presence on the project team. So what does this tell us? I think it tells us that when human factors work is visible and its impact is communicated effectively, it doesn't just improve local practice, it can influence policy, it can shape national standards. And really that's what knowledge mobilisation is all about, is sort of sharing that knowledge wider so that it has a much more broader impact. So, what can you do to try and help this same sort of knowledge mobilisation in your own projects? So I think there's a few things that you can do, and there's probably going to be more. So if you think of other things that maybe you have done, or there are ideas that spring to mind as I'm talking, please share them. I think this is a list of 6 that we can most likely build upon. So here are just some ideas to get you started. So I think human factors work only has impact if it moves, if it's mobilised, if it travels beyond the project that it was created for. So we can often do that through stories. I've done some storytelling today about projects. I've very purposefully not used much text on my slides. I've not bombarded you with statistics or analysis. I've told you stories. And I think for each human factors project, we can tell a short story. We can talk about the problem we saw. We can talk about the insights we uncovered, the actions that were taken and what changed for people doing the work. And I think that sometimes those stories are almost the best training that we can do. They can make human factors findings more socially shareable, but also they can resonate with people much more from an emotional perspective. I think we can mobilise by reusable assets. So in every human factors projects we produce, we are going to generate things like process maps. Maybe we're going to generate some personas, some insights or some design heuristics. And if we can use these and turn them into maybe simple shareable tools or infographics, things like that, we may end up with assets that other teams can pick up. Maybe other teams can actually apply some of the principles so that the knowledge that we have generated can spread beyond the original context. Thirdly, we can maybe mobilise knowledge through capacity building. So I think some of the best human factors teaching that I have done has not been in the classroom at all. It's been working alongside people undertaking human factors projects. And through those conversations, through those pieces of work, you're almost doing that bite-sized teaching. There's a bit of shadowing going on. And I think that does over time really start to infiltrate. And I have found, particularly in a project I did in ED a number of years ago, that people started calling me after the project, not because they wanted me to come and do something from scratch, but they'd had a go at doing some improvement stuff and applying the HF knowledge that they had, and they almost wanted me to come and mark their work, if you like. But I know that they wouldn't have done that had they not worked alongside and sort of seen how human factors could be used. So that for me was actually the most satisfying part of the work, not the project itself, but I suppose the legacy that it had. We can mobilise human factors by hopefully embedding human factors into decision making. So that might be things like building human factors decisions into maybe procurement decisions. It might be that we can get some human factors checkpoints into, I don't know, governance structures, or maybe business cases, thinking about describing workload or usability considerations, team considerations, etc. So by slowly building these human factors elements into decisions that happen anyway across the hospital, again, that's another way of people starting to think about human factors. And I think, you know, when human factors can change a decision for the better, then that really helps to show its impact. We can think about visualization. So a lot of human factors insights are left invisible unless we actually draw them out. So, you know, maybe we do things like before and after workflow diagrams, or we do some journey maps, or, you know, we make it easier for people to visualize what has actually happened. And that might be done in lots of different ways. With the ED project I talked about, I did a plan of the ED department and showed graphically the old process and then the new process. And I think that was so much easier to help people see what had actually happened rather than me trying to describe it. And then that can be used for other people to sort of talk about human factors rather than trying to remember all the terminology. They can actually show these visuals. They can be shown in meetings or wherever really, but it helps to sort of let that knowledge travel. And then lastly, co-ownership. You know, when human factors, when teams feel that the human factors work is theirs and it's not something that's done to them, it's something that is being done with them, I think it spreads more organically. People talk about it, they share it with their colleagues, and I think they often adapt to new situations as well. So I think working alongside people and really helping them feel like it's theirs can help them spread the message as well. So again, please put this in the chat, or if anybody wants to come off mute, then please do. 2 questions for you to think about now, maybe also to let float around your mind for the rest of the day, is number 1, what barriers stop you from making human factors visible in your projects? And having a think about some of the things I've mentioned today, you know, are there any ways you think that you could highlight human factors in your next project? Is it a case of using more human factors terminology in reports? Is it a case of using involving end users earlier, or thinking about human factors in your implementation plans? So just have a think, you know, what are the barriers to you making human factors more visible? And do you have any thoughts about how you can make human factors more visible in your next project? So please feel free to pop in the chat. I'll see if I can get you back.
There's been some really good examples in the chat, Fran, in answer to your earlier question about where people have used it. The range of things people were putting in was brilliant. Really enjoyed reading it, all the different examples, and actually picking up on what you've just said about you involving end users in the work. There's been some great conversation about involving patients and families in
great
research and how that can take a human factors approach. And I think there's a future seminar on how we can combine human factors and patient involvement work.
Absolutely.
So yeah, some really great conversations.
Excellent.
The first thing, I don't know if you can see the chat, so
I can see it now, yes.
The biggest barrier faced is lack of buy-in from senior management, that it's worth supporting.
Yes, I think that's a really, really common one, to be honest. There's no simple answer to this. What I would suggest from my own experience, but then having spoken to other human factors specialists, is that sometimes you need to go around a few managers, even up to sort of exec director level, and, you know, have a chat with people. And often you will find that there is somebody who either knows about human factors as a science, or doesn't actually really feel that familiar with the term, but is quite instinctively thinking in that way. And you almost need to sort of find that champion. I think a lot of us have had success finding champions in clinicians. I struggled for a long time when I was in an NHS trust because I was a lowly band 7. What did I know? And I managed to find a really good consultant who really championed human factors. And the reality was he could get into meetings that I couldn't because he was a consultant and I wasn't. But he was very much of the opinion that where possible, he would knock on the doors and open them, and then he'd push me in first. So I think, I don't know of any trusts that have just been, yes, come in, let's talk about human factors. I think you have to go around quite a few people, go and sort of set your stall out and, align yourselves with the people who really get what it is and can help you champion it further. See if there's any other.
That resonates with what we were hearing from Laura Pickup in last autumn as well. Picking people, and I know I've had conversations with senior managers sometimes that say, oh yes, I know all about human factors, and then in the next sentence reveal that their understanding of it is one bit of it that's not necessarily the whole picture. So trying to help people understand what it is part of what we're doing as well.
Absolutely.
There's a question that we have talked about a lot, Fran. And it's come up multiple times. If there's a parallel between quality improvement and human factors?
It's something that's debated all the time, isn't it? I mean, you ask this question to 10 people, you'll get 10 different answers. In healthcare, I think quality improvement is what has been championed, and you'll often get quality improvement teams. Very, very rarely will you get a human factors team. I think quality improvement, human factors, we're all trying to make improvements. The way that we get there, it might be different. With human factors, we're looking at making improvements, but with the people at the centre of what we do. We're not focused on necessarily shortening waiting times, getting more patients through. We're trying to make the process better for people. And I believe that as a result, we can often then improve the figures. But that is our focus. And I think that is how human factors differs. Now, I'm very much of the opinion that we should just all work together. We will have toolboxes with probably different tools in, but we shouldn't be competing against each other. I think strength in numbers. So yes, we are different to quality improvement, but I think there are some quality improvement methodologies that are good that I would happily use and do happily use. And I'd like to hope that if we worked alongside them, that we would be able to teach them some bits as well, and together sort of work and be a bit stronger in what we do. I don't know if that answers Erin's question, but that's certainly my opinion of human factors and quality improvement. But I just wanted to pick up on Rebecca's, which has also been picked up again about the term human factors not being very helpful and seem very vague. Absolutely agree. Absolutely agree. And one clinician said to me a number of years ago, she said, the term ergonomics isn't that known by people. The term human factors isn't that known, a bit vague. And the fact that you've got two names just makes it even more confusing. And I couldn't disagree, really. The number of, I've been a human factor specialist for, a long, long time, and I never stop having to explain what I do. And my elevator pitch is different depending on who I'm talking to. So I don't have the answer to that, but I would absolutely agree that I think sometimes we don't necessarily help ourselves with the terminology.
There was a question earlier in the chat from Will, which you might not see because it's a bit earlier. Going back to your example of the work you did with nuclear and the proactively looking at shift patterns. What did the human factors analysis tell you? Did it support the move to 12-hour shifts, or how did that factor into the
It did, yeah. So we didn't find any significant difference in terms of alarm response rate going up. There was no significant difference there. There was no significant difference between baseline data and trial data on the number of incidents. And whilst there were inevitably some staff that didn't want to go on to 12-hour shifts, ultimately, because we felt that there was no difference in safety, there was no risk, staff went to a vote, and they voted to go on to 12-hour shifts. One of the things that we also did, which I didn't mention, was at the time, the Health and Safety Executive had a tool which helped you to analyse shift patterns. So we would plug in the shift pattern that staff were doing into this tool, and it would look at things like whether shift patterns were forward rotating, backwards rotating, the number of shifts they were doing in a row, the amount of time they had off between shifts, and it would sort of give you a score essentially as to how good the shift pattern was. And so when proposed 12-hour shift patterns came out, we were able to plug those into the same tool and really sort of indicate, okay, it's not just a case of saying we're going to move to 12-hour shift patterns. You actually still need to think about what that shift pattern looks like and how it is designed as well. And that's something that tool isn't on the Health and Safety Executive website anymore, but it has been taken and developed into a commercial tool. So there were lots of factors that went in it, but I was really pleased that the human factors work did really play a big part in the decision about whether to go to a vote or not. Had we decided that actually it wasn't safe to do 12-hour shifts, it wouldn't have even got to a vote. Okay, so I'm mindful of time, so I'm just going to go back to the presentation just to finish off and just to tie it all up. But firstly, thank you for your contributions today. There have been some really excellent comments. What I've tried to do is to explain not only what human factors means in projects, but how to recognise it in your work, and possibly most importantly, how to make it visible so that it influences practice and policy. And I know one of the things that I think it was Laura Pickup said in your session last year was that sometimes we have to do human factors by stealth. And I absolutely agree with that. And I've done human factors by stealth many times. However, I think there are also opportunities, and it's important not to miss them, when we have to really recognise what human factors means to the piece of work that we've undertaken and how we make that visible so that it hopefully can influence practice and policy beyond the piece of work that we're doing. So I hope that making human factors visible isn't about acting extra work. That's not what I intend it to be. It's about really trying to amplify the impact of what you're already doing. So thank you once again, and hopefully we can all keep mobilising human factors knowledge for impact. So I look forward to hearing any last comments and any thoughts about how you might go ahead and do this. So I'll stop sharing now.